You know that moment when the surgeon says, "I'd like to schedule you for surgery," and before you've even thought about it, you've already nodded? Not because you're certain, because the room expected you to, because the next sentence was already about dates, and the one after that was about paperwork, and somewhere in there the decision got swapped out for a schedule. If you are over 65 and a surgery has been recommended, or you feel one coming, there is one thing the scheduling conversation almost never covers, and it is the thing that determines your outcome more than anything that happens in the operating room. Today you're going to know what it is. Before we get into it, if you're someone who wants to understand what's actually happening inside your body, not just what to do but why, and not just why but what you can do about it starting today, you're in exactly the right place. This is Doctor's Plain English. Hit subscribe so the next video finds you before you need it, not after. I'm Dr. Hannah Fields, and in 15 years of clinical practice, the patients who recover best from major surgery are almost never the ones who were healthiest going in. They're the ones who knew what to do with the time they had before they got there. Here is something the standard surgical appointment almost never has time to cover. Surgery is not something your surgeon does while you wait. It is something your entire body has to perform, survive, and then climb back from. Every organ, every system, simultaneously, while you're unconscious and unable to help. And for adults over 65, that reality has a specific clinical name and a specific set of consequences that most patients are discharged without ever understanding. The name is physiologic reserve. Think of it as your body's emergency fund, the stored capacity it draws on when something major demands more than your normal daily output. When you're 40, that fund is deep. Surgery makes a large withdrawal, your body covers it, and within days or weeks you're rebuilding. When you're 70, that fund may be lower, not because something is wrong with you, but because normal aging draws it down slowly over decades, the way ordinary expenses quietly reduce savings you didn't know you were spending. What this means in practice is that the same operation, performed by the same skilled surgeon with equal precision, carries a genuinely different risk profile in a 45-year-old body than in a 75-year-old one. Not because older patients are fragile, because their margin for the unexpected is narrower, and the unexpected, a small infection, a medication interaction, a slow kidney clearing the anesthesia, happens in surgery more often than the preoperative brochure suggests. A 2019 analysis published in JAMA Surgery examining surgical outcomes in Medicare patients found that postoperative complications in adults over 75 were significantly associated not just with age, but with pre-existing functional status, meaning how strong, how mobile, and how nutritionally supported the patient was before they ever walked into the operating room. That finding matters enormously because functional status is not fixed. It is something you can actively change, but only if someone tells you that before the surgery date is already circled on a calendar. That is the gap this video closes. Not a gap anyone created on purpose. There is simply no formal moment in the standard surgical pathway where someone sits down with a patient over 65 and says, "Here is what you can do right now to change what happens on the other side of this." Today, I am that moment. Let me give you one way to think about this that I find genuinely useful, and I want to unwrap it slowly because it changes how you see everything that follows. Imagine you are about to run a race. Not a gentle jog, a real race. The kind that asks everything of you physically. Now imagine you find out about the race 2 months in advance. You have time. You sleep better. You eat deliberately. You build your legs and your lungs. You show up on race day with reserve you didn't have before. Now imagine you find out about the race the morning it happens. Same race, same distance, same course, but you're running it on whatever you happen to have that day, whatever you ate last night, however well you slept, however much your knees were already bothering you. Surgery is the race. Your body is the runner. And here is the thing almost nobody in that scheduling conversation mentions. Most people have weeks, sometimes months, between the recommendation and the procedure date. That is not waiting time. That is training time. That is the window where the race you run on the other side of anesthesia gets decided. Not in the operating room, but in your kitchen, on your block, in a conversation with your doctor about two numbers in your blood work. The runner who trained and the runner who didn't may walk into the same operating room on the same morning, but they are not running the same race. I think of a patient I'll call Miriam, whose story reflects a pattern I encounter more often than I'd like. Miriam was 74, recently retired, the kind of woman who organized everyone else's lives so efficiently that she rarely stopped to tend to her own. She'd been managing knee pain for about 3 years. Her orthopedic surgeon recommended a total knee replacement. Reasonable recommendation. She had the imaging, she had the symptoms, she was a genuine candidate. But when Miriam sat across from me, what I noticed wasn't her knee. It was that she looked tired in a way that 3 years of knee pain alone doesn't explain. Her skin was a little pale. She mentioned she hadn't been eating much because cooking had become harder with the pain. She was taking an over-the-counter sleep aid most nights. And her last blood panel, which nobody had flagged to her as relevant to the surgery, showed two things that mattered enormously. Her hemoglobin was low, she was anemic, and her blood sugar control was borderline. Miriam was 4 weeks from her surgery date. She hadn't been told that either of those things was a surgical issue. She thought they were just background noise, the ordinary accumulation of getting older. She was about to walk into an operating room with a savings account running on fumes for a race she didn't know she was supposed to train for. We had a conversation that afternoon that changed her outcome. I want to give you the substance of that conversation right now. Here are the 4 things that matter most. Ordered by genuine clinical weight, not drama. Each one is more useful than the last. The first point, and the one with the most immediate consequence, is that anemia before surgery is one of the most common and most correctable risk factors in older adults, and most patients don't know to ask about it. Anemia means your red blood cells aren't carrying enough oxygen. During surgery, your body needs oxygen delivered efficiently to every tissue being cut, repaired, and healed. If you go into the operating room already running an oxygen deficit, you're asking a delivery system at 70% capacity to handle a sudden surge in demand. Research published in the journal Anesthesiology found that preoperative anemia in elderly patients is associated with significantly increased risk of blood transfusion during surgery, longer hospital stays, and higher rates of postoperative complications. Here is what makes this clinically important rather than just alarming. Iron deficiency anemia, one of the most common types in older adults, can often be meaningfully improved with supervised iron supplementation over 6 to 8 weeks. A simple blood test, a complete blood count, tells you and your doctor where you stand. Miriam's anemia was iron deficiency. 8 weeks of iron supplementation, supervised by her internist, brought her hemoglobin into an acceptable range before her procedure. What you do right now, call your doctor's office this week and ask specifically for a complete blood count. Ask them to look at your hemoglobin. Ask whether there's anything to address before the procedure date. That call costs nothing and could change everything. The second point, and this one surprises almost everyone who hears it, is that blood sugar at the time of surgery is not a background condition. It is an active surgical variable, and it is one you may be able to shift. Elevated blood glucose impairs wound healing, increases infection risk, and slows the immune response. Simultaneously, at exactly the moment your body needs all 3 functions working at full capacity. A 2020 review, published in the journal Diabetes Care, found that patients with HbA1c, that's a 3-month average of blood sugar control, above 8% at the time of elective surgery, had significantly higher rates of postoperative infection and prolonged hospitalization compared to patients whose blood sugar had been brought under better control in the weeks prior. That is a window you can work in. 6 to 8 weeks of focused blood sugar management, more protein, fewer refined carbohydrates, consistent daily movement, and in some cases a medication adjustment with your doctor can shift that number in a clinically meaningful direction. Miriam's endocrinologist adjusted her medication and worked with her on nutrition for 7 weeks. Her HbA1c came down a full 1.5 points. That is not a cosmetic change. That is her immune system functioning differently on the morning of surgery. What you do right now, If you have diabetes or borderline blood sugar and a surgery is on the horizon, call your doctor this week and say these words. I want to optimize my blood sugar before the procedure. Ask what's achievable in the time you have. Let them set the target. Your job is to show up for the work. The third point, the one I wish every pre-surgical patient heard, because it costs nothing and the evidence behind it is real, is that what you do physically in the weeks before surgery changes your measurable outcomes on the other side. This has a clinical name, prehabilitation, prehab. It means intentionally building physical reserve before a procedure, the way an athlete builds fitness before a competition. A 2018 systematic review published in the British Journal of Sports Medicine found that prehabilitation programs, even short ones, 4 to 6 weeks, reduced post-operative complication rates and shortened hospital stays in older surgical patients. The components are not complicated. Daily walking, even gentle, preserves leg strength and lung capacity, both of which prevent the two most common post-operative complications in elderly patients, blood clots and pneumonia. Protein at every meal, because protein is the raw material your body uses to rebuild tissue, and most adults over 65 are quietly eating less of it than they need. And if you smoke, stopping even 2 weeks before surgery measurably reduces lung and wound complication risk. 2 weeks, not years, 2 weeks. Miriam walked around her block every morning. She added eggs to her breakfast and fish to her dinner twice a week. She was not training for anything athletic. She was a 74-year-old woman deciding to show up to the most physically demanding day of her year as strong as she could make herself. And she did. The fourth point, and this is the one that sits underneath everything else, the one that makes all three of the previous points possible, is that a surgical recommendation is the beginning of a conversation, not the conclusion of one. And the questions you bring to that conversation are the most powerful clinical tool available to you. There are 3 questions every adult over 65 deserves answered before any major procedure. First, what happens if we wait, monitor carefully, or try a non-surgical approach first? A good surgeon gives you an honest answer to this. If nothing urgent changes in the next 3 to 6 months, you have time. Time to optimize, time to get a second opinion, time to ask the next question. Second, is there a less invasive version of this procedure? Medicine has changed substantially in the last 15 years. Robotic-assisted surgery, endoscopic approaches, catheter-based interventions, options that didn't exist a decade ago are now available in most major hospitals and often carry meaningfully lower risk profiles for older patients. Third, what does recovery look like specifically for my age and my health profile? Not the average patient, but me, with my heart, my kidneys, my current medications, and my living situation. The answer should be specific. If it's generic, you don't yet have enough information to sign anything. These are not difficult questions. They are not rude questions. They are the questions a good surgeon expects, and the best ones welcome, because they would ask the same ones for someone they love. I want to ask you something, and I genuinely want your answer in the comments. When you or someone you love has been told surgery is recommended, what was the very first feeling in your body in that moment? Not what you thought, what you felt. Because I think the answer to that question tells us something important about why the nod happens before the decision does. Tell me down below. I call the approach I walked Miriam through the pre-race protocol. 4 steps, in order, for every adult over 65 who has a surgery on the horizon. Step 1. Know your numbers. Before your surgery date arrives, get the blood work that matters: hemoglobin, HbA1c, kidney function. These are not formalities. They are the starting line of your preparation. Step 2. Fix what's fixable. Anemia, blood sugar, blood pressure. These are active surgical variables you may be able to shift in the weeks you have. Work with your doctor. Set a target. Start now. Step 3. Train for the race. Walk daily. Add protein deliberately. Stop smoking if you smoke. The body you build in the next 6 weeks is the body that recovers. Step 4. Ask the questions out loud. Write them down before the appointment. Bring someone with you whose only job is to listen clearly when your own mind goes foggy with the weight of it. Ask everyone. Tonight, add a meaningful source of protein to your next meal: eggs, fish, legumes, Greek yogurt. Tomorrow morning, call your doctor's office and ask for a pre-surgical blood panel, and ask whether your hospital offers a prehabilitation program. Before your next surgical appointment, write your 3 questions on paper, not in your phone, on paper, because paper goes into the room with you and doesn't lock or run out of battery. Bring someone with you who can hold those questions steady when the room starts moving faster than you expected. And in the days after any surgery, know the warning signs that mean you call immediately. Sudden confusion, a calf that is swollen, warm, or painful, fever, a wound that looks angrier than it did the day before. Any of those, you call. You don't wait, you call. Miriam had her knee replacement. She went home in 2 days. She was back in her kitchen making dinner for her family within 3 weeks. Not because her surgery was simpler than expected, because she showed up to it as a different patient than the one who first sat across from me. Stronger, better nourished, with numbers that gave her body room to recover. She trained for the race, and she ran it well. The nod in the surgeon's office doesn't have to be the decision. It can be the beginning of one. And everything between that nod and the procedure date belongs to you. Thank you for being here today, truly. If today's video helped you see that window differently, share it with one person who has a surgery coming up or who's been told one might be necessary soon. Not because it's a good video, because that one share might be the most useful thing that person receives before they walk into that scheduling conversation. And if you're not yet part of Doctors Plain English, subscribe now, because the next video covers something that connects directly to what we talked about today, and you'll want it before you need it, not after. One question to carry with you. Now that you know the weeks before surgery are training time, what is the one thing you're going to do differently before the next appointment? Tell me in the comments. I read every one. Everything I've shared today is for general informational purposes, based on real research and clinical patterns I see often. It isn't a diagnosis, and it isn't a substitute for your own doctor, who knows your specific history. Please check with your physician before making any changes to your medications, diet, or health routine.